This is Anesthesia Circuit with John Kenny, the only show dedicated to all things anesthesia.
Give back and live longer and healthier. The causes of hypercapnia. The CNS changes of aging. Are we measuring blood pressure frequently enough? How can I get money to improve patient safety? And are there meeting dates that I'm missing? This and more on this episode. I'm John Kenny, and this is Anesthesia Circuit with John Kenny, the only show dedicated to all things anesthesia. All right, let's get right into this personal health segment. Today we're going to be talking about volunteering. Now, volunteering isn't a completely selfless act as the literature shows. We actually get a lot back out of it when we volunteer. There's been a growing body of evidence in the last 30 years or so to show a positive relationship between the number of hours that we volunteer and improvements in mental health and in physical health. Now, why might there be this connection? Well, social psychologists point to this idea of social integration theory. What that holds is that, or what that says is that individual social connections provide them with meaning and purpose, but then it also gives them this ability when there's an obstacle to overcome, that they're able to deal with these difficult periods better by leaning on their social support and having better coping skills here. Now, people who volunteer report that they have an increased sense of accomplishment, sense of purpose, and satisfaction, which all played into improved health. Now, a 2015 study comparing college students who worked with those who volunteered reinforced these ideas. The name of this publication was The Impact of Work and Volunteer Hours on the Health of Undergraduate Students, and this was published in the Journal of American College Health. Now, not only did the study show that volunteers reported less depression and felt less overwhelmed, they were also able to stick to a physical activity regimen more strictly. That's right, the volunteers skipped the gym less. So if you find yourself making excuses for eating right or exercising, then you may want to start volunteering because it can help you stick to that regimen. The benefits don't stop at that immediate. These studies also show that there's a long-term physical and mental health benefits from volunteering as well, as evidenced by this 2003 study entitled Effects of Volunteering on Well-Being of Older Adults. And what that study found was that people who volunteered between an average of 1 to 2 hours weekly, so really not that much, in the past, that they reported higher levels of health and physical functioning. So they were healthier overall when they had been volunteering in the past. Now, another recent study published in Social Sciences and Medicine also found that there was an attenuation of the neuroendocrine response to stress by volunteering. So what they did was that they took samples of the study participants' saliva and tested for salivary cortisol. And what they looked at was on days when patients volunteered or when the subjects volunteered versus on days when they didn't volunteer, what level of cortisol was being produced. And what they showed was that there was a statistically significant decrease in cortisol being produced on a day when they volunteered. Now, they were going about their regular daily activities as well, but they just included volunteering on that day. Have you felt disconnected from your patients? Well, you're not alone. This is a growing sentiment across the healthcare world in general by healthcare providers. Well, there was a recent study in 2013, a national survey by Harris Institute, which shows that volunteering results in feelings of a deeper connection to their community and the people that they served in 95% of respondents. Now, interestingly, the people who volunteered were also more engaged in their own health as well. Also, what this showed was that volunteering helps people develop work skills as well, and including time management, stronger colleague relationships, improved teamwork, and improved professional skills. So there's a lot of benefit that the literature shows to volunteering. And one of the interesting things as well is that in a lot of these studies, it was an hour or so a week. that resulted in these increased mental and physical health benefits. So today's keywords are hypercapnia, the causes, and CNS changes as we age. Now for hypercapnia, it's a good way to look at this in two broad categories to start. One is decreased elimination of carbon dioxide, and the other broad category is increased production of carbon dioxide. As for the decreased elimination, it can be further divided into categories of decreased minute ventilation and increased dead space. As for decreased minute ventilation, you have hypoventilation, rebreathing, COPD, a large intrapulmonary shunt. These can all be causes. Now, by far the most common cause of hypercapnia in the preoperative setting is hypoventilation. It's usually secondary to a combination of sedating medicines and body habitus. Now, this falls into the decreased elimination category. Anesthetic medications that can worsen hypoventilation include inhaled anesthetics, opioids, benzodiazepines, and other sedative hypnotics. Now, residual neuromuscular blockade has also been implicated in hypercapnia in the post-op setting. Usually you'll see a patient with that characteristic floppy fish look to them, where they can only engage their muscles for a short period of time. Also, splinting can be a cause of it as well. If they're taking shallow breaths because of the pain, that can definitely decrease your alveolar ventilation. The hypercapnia in ventilated patients, sometimes they need their settings changed. So if the patient is on pressure support, one needs to ensure that there's an adequate tidal volume and respiratory rates. You may even need to switch the patient to volume controlled mode with a set respiratory rate in order to increase the patient's alveolar ventilation. Now, rebreathing, that occurs as a result of incompetent one-way valves or because of exhausted adsorbent. Increased alveolar dead space is the mechanism which underlies the CO2 retention in COPD. Dead space is the non-gas exchanging portion of the lung, and so you're not, even though you may have a normal tidal volume, if you have less alveoli, the alveolar ventilation is what's actually involved in the gas exchange. Now, causes of increased CO2 production are all hypermetabolic states, apart for insufflation of the abdomen during a laparoscopic procedure. Now, these include malignant hyperthermia, fever, thyrotoxicosis, increased catabolism like in sepsis or steroids, overfeeding, exercise, metabolic acidosis. Now, increased production is rarely the cause of elevated CO2 because the compensatory mechanism is to increase ventilation, and that usually takes care of it pretty effectively. Now, however, if there's impairment in the ability to increase alveolar ventilation, this can be a problem. So in a COPD exacerbation, respiratory muscle weakness, sedation, those cases can result in it. Now, I talked about the systemic absorption of CO2 gas during laparoscopic procedures can also cause an increased production, so to speak, of CO2. Now, remember, patients that are receiving high carbohydrate diets will need higher alveolar ventilation in order to eliminate the excess CO2. So if you got the patient who is being ventilated, who's on tube feeds or TPN or something, if it's high carbohydrates, they may need a higher ventilatory requirement in order to eliminate that carbon dioxide. This is because of the respiratory quotient. Now, the respiratory quotient is a ratio of CO2 produced by the body to the oxygen consumed by the body. Now, remember that this respiratory quotient is seen in the alveolar gas equation here. It's seen on the end, okay? And now these numbers I've seen this tested before as well. So the typical mixed, if you have a mixed diet, a normal diet, your respiratory quotient is going to be 0.8. But if the respiratory quotient is 0.7, that indicates that lipids are being metabolized, 0.8 for proteins, and 1 for carbohydrates. So you can see that it's much higher in carbohydrates. Now note that capnography can be a surrogate for detecting hypercapnia. However, it may not be accurate in patients with large physiologic dead space, if the patient's not intubated and this is just a nasal cannula that's detecting it. And so you want to look at the ABG if you have a question, because that's going to be your definitive diagnosis there. Now, as for the advanced question, this is the CNS changes in aging or as we age. So we have, we're breaking it down into anatomic and physiologic changes, the cognitive and behavioral changes, and then we're going to talk about how the anesthetic medications are affected, and then a little bit about POCD or postoperative cognitive dysfunction. So anatomic and physiologic changes. The volume of the brain decreases by about 7 centimeters cubed per year after the age of 65. Now, the greatest loss is in the frontal and temporal lobes, and there's a greater loss in white matter than gray matter. So this shrinkage leads to a larger subdural space and ventricular space, which helps to explain why elderly patients are at higher risk for subdural hematomas. Cerebral blood flow also decreases heterogeneously by 5 to 20% in older patients, with deterioration of the mechanisms that maintain cerebral blood flow with fluctuations in blood pressure. So your autoregulatory mechanism isn't as sound as we age. Now, age-related neuronal loss is most prominent in the largest neurons of the cerebellum and cerebral cortex. And age-related neuronal dropout is most likely due to apoptosis. Neurons continue to form new synapses and new neurons are formed throughout your lifespan, but the rates of loss are greater as we age, and that accounts for this loss in volume, or that's a reason for the loss of volume. Now, multiple changes in brain enzymes, receptors, and neurotransmitters occur with age as well. Acetylcholine availability decreases due to the decrease in cholinergic and muscarinic neurons, and reduced release and synthesis of acetylcholine. Also, dopamine and corresponding receptors in the striatum and substantia nigra are decreased as well. Now, for cognitive and behavioral changes, the episodic working memories and executive functions are the specific areas where cognition is most affected by normal aging. Processing speed decreases with age, executive function decreases, especially more after 70 years old. Attention span decreases, problem solving, reasoning about unfamiliar things, processing and learning new information, and attending to and manipulating one's own environment shows a steady decline as well. Now, older patients have disturbed sleep-wake cycles, and there's an increased threshold for many sensory modalities, including touch, temperature, sensation, proprioception, hearing, and vision. So there's a real hit to the sensory input. Now, common anesthetic medication classes and then their CNS effects in the aging population. Now, volatile anesthetics, elderly patients require less volatile. Now, their MAC decreases by about 6 to 7% every decade after 20. So that's not even elderly, that's young adults. It starts declining. Now, as for propofol, both the induction and maintenance doses are decreased. And then propofol's hemodynamic effects will be really exaggerated in older patients as well. Now, for opioids, elderly patients require a smaller dose for the similar effect. They have increased incidence of respiratory depression, increased duration of systemic and neuraxial effects as well. With benzodiazepines, they display a significant increase in duration of action. Long-acting benzos like lorazepam, diazepam have been associated with delirium in elderly, so try to avoid those. As for atropine, the dosing may need to be increased as well. And then also, neuraxial anesthesia can be problematic because of the exaggerated spread of local anesthetic in the epidural space. Also, a long duration of action is expected from the spinal anesthetic in elderly patients. Now, as for post-op cognitive dysfunction, or POCD, this is a cognitive disorder unique to patients after anesthesia. Unlike delirium, patients with POCD are not acutely confused or agitated. Up to 10% of older patients age 65 or greater develop POCD in 3 months following non-cardiac surgery. The occurrence has been associated with increased mortality as well, and the etiology is most likely multifactorial, including drug effects, pain, underlying dementia, hypothermia, and metabolic disturbances. Now, as for our current research segment, now we all know that intraoperative hypotension is associated with increased risk for postoperative morbidity and mortality. Now, the early detection and treatment of that hypotension intra-op allows us to increase the odds of preventing a negative outcome. Now, our featured article today comes from the August 2018 edition of Anesthesia and Analgesia. Now, in this study, the authors tested the hypothesis that continuous non-invasive blood pressure monitoring reduces intraoperative hypotension. Now, the name of this is a randomized trial of continuous non-invasive blood pressure monitoring during non-cardiac surgery. Now, the study population included patients greater than 45 years old who were ASA 3s and 4s. They were undergoing moderate to high-risk non-cardiac surgery with general anesthesia. Now, all of the participating patients had continuous non-invasive hemodynamic monitoring using a finger cuff, and they also had the standard oscillometric non-invasive blood pressure cuff, that intermittent cuff that we all use. Half the patients that were randomly assigned, half of those patients, the clinicians, were blinded to the continuous values. Now, what they found was that those assigned to continuous blood pressure monitoring had significantly lower time-weighted average mean arterial pressures, and that threshold was less than 65 millimeters of mercury. Now, the authors concluded that although continuous non-invasive hemodynamic monitoring nearly halved the amount of intraoperative hypotension, so there was this statistically significant difference in time of hypotension, but they're not really sure what the clinical importance of this is. So if you want to learn more about this, you want to scour this study a little bit more, you can check out the August 2018 edition of Anesthesia and Analgesia, and you'll find it in there. As for anesthesia news, now have you ever wondered how you can get some money to help do research to improve patient safety? Well, if so, you're in luck. The Anesthesia Patient Safety Foundation and Foundation for Anesthesia Education and Research announced a call for applications for their new perioperative patient safety mentored research training grant. Now, the grant will provide up to $300,000 in funding over a 2-year period. The grant will fund patient safety research directly relevant to the perioperative care of patients, as well as chronic pain and critical care medicine. Now, the ultimate goal is that no patient is harmed in a preventable fashion by the medical care they receive. Applications will be accepted between June 7th, 2018 and December 14th, 2018. For more information about the application process, it can be found at www.apsf.org, so that's the Anesthesia Patient Safety Foundation.org, and www.faer.org, or the Foundation for Anesthesia Education and Research. All right, as for announcements, so ASRA, the Fall Pain Medicine meeting, will be held November 15th to the 17th, 2018 at the JW Marriott San Antonio Hill Country Resort in San Antonio, Texas. Early bird registration ends September 28th, 2018. Also, the Society of Pediatric Anesthesia's 32nd annual meeting will be held October 12th, 2018 in San Francisco, California. Early registration ends 8/24/18. Thank you again for joining me today. I hope you got a lot out of it. Please join me next time as we dive into the world of anesthesia. This is Anesthesia Circuit with John Kenny. I'm John Kenny. This is the only station dedicated to all things anesthesia. See you next time. Information disseminated in this show are for entertainment purposes only. Please consult your professional societies for the most up-to-date information on practice guidelines. Kenny's Anesthesia Circuit is a Vigilant Medicine Media production. Copyright Vigilant Medicine Media 2018.